Well, good afternoon, everybody, and welcome back to our final session with an external speaker of our 4-day conference. And in lots of ways, this session really helps us think about the future. And so a lot of the conversations that we've been having over the course of the week really feed very well into this session. So I am delighted that we have Danny Mortimer with us, who is the Interim Chief Executive of NHS Confederation. We've got a long-standing relationship with the NHS Confederation, both the Confederation itself, but also a number of its organisations housed within it. So we're really delighted that Danny is with us. I just want to say a few things about some house rules so that we just remind ourselves. You know by now that please put your contributions in the Q&A. We want to hear from you. There'll be opportunities either now or post-conference to make sure that we go over all those questions and get answers. But you give us a lot to think about when you make your comments too. We'll be supported by Bren and Rory. Bren, many of you know, and Rory, many of you all know. Rory is now at the NHS Confed, but he was previously Chief Exec of Healthwatch Kirklees. So it's really great to have you back, Rory, with us for this event. And finally, just to remind you all, we are tweeting about this because people who are not in the conference are also interested in what we're talking about. So don't forget to tweet using the hashtag Healthwatch2020. Now, if I can just introduce our speaker, Danny. I have to say, Danny, you are probably the only person who has a very similar background to me in how you started out in health and social care. Danny started out as a porter and also was a community service volunteer as a care assistant. Now, Danny, I started out as a cleaner in a hospital, and then I was a care assistant in residential homes for people with learning disabilities, two jobs I absolutely loved and gave me a real passion for working in health and social care for most of my life. Danny, you went a better path then. You went into becoming a management trainee, whereas I went off and did other things. But you've had a really broad range of experiences, both in Stoke-on-Trent and then Bath and Brighton and West Sussex. And also, I know of your work at the NHS employers as well, a really important role that you had here. So it's great now that you're the interim check of the NHS Confed, and we're really looking forward to working with you on this. Now, Danny, you have a PowerPoint for us, don't you? So if you could move to that, please.
That would be great, thank you. And I think colleagues are going to display that for me. Thank you so much, Imelda, for those kind words of introduction. And yeah, all the best people started as porters or cleaners in my experience within the NHS. And before I do start, ladies and gentlemen, we're really grateful on behalf of the Confederation for letting us recruit Rory from Kirklees a few years ago, but for having me today and for the support and advice we've had from Healthwatch, both during the pandemic, but over quite a long period beforehand. What I wanted to do with you was to share some of the reflections that we have presented on behalf of members over this last month or so through our programme of work called Reset. Before I do that, to give you some sense of the context and circumstances that the NHS finds itself in now, and then to conclude by talking a little bit about the needs of the NHS in the future, particularly through the prism of the spending review, the one-year spending review we're expecting from the Chancellor at some stage before Christmas. I think by way of introduction in terms of context, clearly where we are now is that both for the population at large, but also for people who work in health and social care, people are tired. I think they're worried. The announcement from the Chancellor just a short while ago about the extension of furlough to the end of March will have eased some worries for some people. But clearly, we are in the most exceptional of years and the most exceptional of circumstances, and that takes a toll on all of us. And particularly in terms of, but also takes a particular toll of the most vulnerable in our communities. For NHS services right now, I think they see four factors that they're trying to manage, and there's some trade-off between all of them. There clearly is the response to COVID. And I spoke to a Trust Chief Executive this morning in the Midlands, which is where I live now. And what she was describing was a hugely accelerated rate of infections and admissions, both to their critical care, but also their general and acute beds. She was also, secondly, then trying to maintain her non-COVID services, particularly in her most urgent specialties. Cancer and other specialties were mentioned. She's trying to get ready for winter. The activity that she knows that will bring. Flu season hasn't started yet. The particular pressures we get from the cold weather impacting on our population, and particularly our elders, hasn't as yet been fully experienced. And also, along with colleagues across the rest of her area, they're preparing for a mass vaccination programme. And of course, it's the same staff, the same resources and facilities, the same patients that are being treated across all of those 4 domains. And there is a sense that there are some trade-offs that people are desperate not to have to make, but they will make. If I could have my first slide proper, that would be great. Thank you. Thanks, Bren. What we did as a result of the pandemic, though, just to kind of go back to where we found ourselves in the summer, I think it was very clear to us, it was very clear to our members that the pandemic had helped us accelerate changes that we've been perhaps trying to make for some time. It had enabled us to do some things new and very differently, but it also highlighted some long-standing challenges in pretty stark and disturbing relief. And what we did over the course of the summer, and Rory in particular played the key leadership role for us in doing this work, we engaged with a whole range of senior leaders, including from Healthwatch, through a whole range of activities and meetings, to try and draw together some lessons that needed to be learnt by the health and social care system from the experience of the pandemic. I think the first thing was about honesty and realism, and that there was something about expectations of what it is that health and social care services could do, both in terms of the next phase of the pandemic, but also longer term. And that clarity of communication is clearly something that has been challenging for us as a country in relation to the pandemic, but probably longer term as well. We wanted to see a lighter, leaner culture. In particular, we wanted there to be a less centralised approach to managing the NHS. Our members were very clear that in that context, in those circumstances, that actually that gives them more freedom to work with each other and with their local communities and populations to actually better co-produce services. We wanted to see that tremendous integration that we saw and collaboration that we saw during the pandemic. We wanted that momentum there to continue. And in particular, we want to see legislation from the government which enables that and make sure that actually that collaboration is now the default setting for the NHS, and that we don't return to the kind of competitive market style way of working that has kind of overshadowed most of my managerial career in the NHS. We were very clear, and our members were very clear, that the pandemic had highlighted significant inequalities, particularly for Black and minority ethnic communities, but for lots of other communities in the country as well. There are clearly a number of risk factors that are associated with COVID, not least age and underlying health conditions, but it's very clear that poverty is also one of those risk factors. And then finally, we were very clear that actually the lack of capacity we were experiencing, the pressures that there were because of the pandemic, meant that we needed to see extra funding and investment in health and social care for the longer term. Can I have our next slide, please, Brent? Just head the other way. Thank you so much. So as I said, that funding gap is caused by the operational costs of the COVID response, assuming that we have to live with the virus for some significant time yet. We are running our services very differently in every setting, whether that's in the GP surgery or the pharmacy or the acute hospital. We're having to make different arrangements in order to protect our patients and obviously our staff. The capacity constraints are then really important and will be with us for a real good time yet. And clearly we need to build greater resilience for the future. and we have to be better able to respond to resurgence of the virus, or God forbid, some other pandemic in the future. Brenna, next slide. I think it's also, of course, the case that we saw real pressures and problems in the NHS before the pandemic came along. We haven't delivered the 4-hour standard in emergency departments for 5 years now. We saw far too many patients waiting for diagnostic tests. Our performance against the 18-week target was some 10 to 15% short of where it needed to be in terms of that commitment that we've made to the public. And we also see in a number of other settings that there just aren't the facilities that are available to support our staff and obviously provide the best care possible to our patients. And we cite there the BMA survey of their GP members regarding the lack of quality that we see in far too many of our primary care facilities. Next slide, please, Bro. Similarly, of course, we've also experienced through the first phase of the pandemic and now as we enter into the second phase of the pandemic, significant delays to treatment for patients. And whilst our members have made real efforts to maintain activity during the pandemic, whilst there was a really sensible arrangement reached with the private sector as well, whilst people have worked really hard to restore elective capacity through the summer months and into the early autumn, what we do see is a significant backlog now of waiting times. And what we're also seeing, of course, is patients that haven't come forward for treatment, patients that haven't got into contact with their primary care services in particular. And we're obviously encouraging people to seek treatment if they're worried, but we know we've got a backlog of those really fundamental aspects of care that people just weren't able to access or probably more commonly didn't feel able to access at the height of the pandemic. Next slide, please, Bren. What we've said to the Treasury is that in the face of those circumstances, the long-standing issues that restricted the NHS's ability to respond to the pandemic, the backlog that we're seeing now grow in terms of treatment, the restrictions that are placed on us because of the pandemic, the implications there are for patients, both in terms of long-standing care, but possibly also some new areas of care, mental health, long COVID, for example, that actually we said on behalf of our members that there are a number of areas that we believe need particular attention from the Treasury. The first is that actually health and care, and particularly that action to reduce inequalities in health outcomes for the public, needs to be at the heart of the spending review. It needs to be reflected in every area of public policy. You will know from your work, you will know from your communities that yes, there is more the NHS must do. Yes, there is more that local authorities can do, but actually there's a whole range of public services that need to consider health and health outcomes in their work. The second thing, as I've touched on a number of times, is that the demand for our services is massively increased in the face of restricted capacity, and actually people waiting for treatment isn't acceptable. I've worked in the health service, as Imelda's touched on, for some 30 years or more. For a brief period in the mid-90s, I was a general manager in orthopedics, and I can well remember the 18-month or 2-year waiting lists that we had for major joint replacements. And none of us want to return to that way of treating patients for any length of time. And as I said, we've also got to be able to deal with some new demands. We all anticipate, both because of the virus, but also particularly the impact of the economy and the economic downturn, a real increase in demand for mental health services, for example. So we need that additional investment. We need to see resilience, and we need to be able to deliver for the longer term. And in particular, we need to see a better and longer term plan for investment in capital. If you look at the reset programme, an enormous amount has been achieved in terms of use of technology. Some of that we'll need to switch off as we get beyond the pandemic, as we start to return to some more normal ways of delivering services, particularly in community settings. But actually it has shown the potential of technology to increase access for patients and the public, to help our clinicians work more effectively with their patients. But frankly, we need a longer term plan now to invest in technology and facilities. We don't necessarily criticise the government for repeatedly announcing they're going to build 40 new hospitals or bits of hospitals, but they need a plan which speaks to all healthcare settings, all areas of capital investment, and that needs to be a truly long-term plan. The fourth issue is the workforce is overstretched. It was overstretched before the pandemic came along, and actually lack of depth within our workforce has only been illustrated by the experience of responding to the pandemic. We need additional investment, particularly in the educational supply route. The government, in fairness to them, have taken some steps on the back of their election victory a year ago, but we need, again, a more sustained and longer term plan to grow our workforce. We are rightly worried, as you would expect us to be, about the health and well-being of our people. Enormous amount of support in place now in organisations to do that. But what we hear and what we see is that by addressing those vacancies, addressing those gaps for the longer term, we give people some hope that they will have fully staffed services and rotas. And obviously that's also the single best thing we can do to try and help their health and well-being. And then finally, and really importantly, the government has to have a plan for social care. It has to have a plan which both focuses on stabilising social care in this next year or two, some steps there in terms of plans for this winter. It has to have a transitional arrangement, because completely reforming the way in which we deliver and charge for social care is a significant undertaking. And then we need a truly transformational long-term plan for social care. And successive governments of all colours and combinations of colours have failed to engage with this issue. So those are the kind of things that we've highlighted in our conversation with the Treasury. I think it's a particular prism through which we can talk about the priorities for our members, and I very much look forward to talking to you about them further in the next Q&A. I think that was my final slide, Bren. Thank you so much. I'll stop at that point, Imelda, and I'm very happy, obviously, to start the discussion and take any questions about anything I have said or anything I should have said.
That was great, Danny. And I should also say that Healthwatch has had opportunities to contribute to the work of the NHS Confed Reset programme. We had 2 workshops that Rory and Bren organised, and they were really well attended, and many of you have contributed to the thinking behind this. And we also contributed at a national level, both into some of the thinking and some of the workshops. So, so it was great. Well, thank you for inviting us to be part of it. We were pleased to be part of it. There were a few things that came up for me as you were talking, Danny, just a few reflections, and some of them are some of the issues that came up in our last workshop. Now, I was talking to you before we started about our last panel session, and that was very much about the way we work together in the future. And it was about some of the NHS jargony stuff about NHS systems, system first, and all that. Now, there were a couple of things that were said in that panel sessions that I thought that really stuck with me, resonated with me, but really stuck with me. The first one was, I think we've all got to stop and think, what is normal now? Not what's the new normal, but what is normal now, so that we can redefine and build and grow from that. And the other thing I thought that was really interesting is the panel picked up this language that they all used, which was, this is a one-way valve. We've come through this valve, there's no going back. We now have to keep on going in the right direction through this valve for the change that we want to see. And one of the other things that came up, and this was particularly Sarah Pickup, who is from the Local Government Association, and it really resonates with what you said, Danny. You talked about a lighter, leaner culture. She talked about trusting local leaders to make good decisions for their population, and that was also sort of picked up quite a bit by Steve Barrack, who has done a lot of work on health and social care devolution and where decisions should be made. And it was quite a lot of that, very similar. We need lighter, leaner, we need frameworks from the centre, but not heavy-handed command and control from the centre. So much more trust and the idea that we saw people really operating in a great way once they were given the freedom and the opportunities to operate with their partners locally. The thing I think that's because Healthwatch covers both health and social care, we have this sort of very broad overview, and because we look at it through the prism of people's eyes, so it's the same people who are waiting for the surgery who are also their day centres are not open, still haven't been open since March, who have probably mild dementia and are being looked after by a daughter who's trying to work. So we're talking about the same people, we just look at them through a different lens. And one of the things I think that's come up very clearly for us is the importance of not just having resilience in the NHS, but also having resilience in wider communities. Because actually, when the pandemic hit us, it was local communities who really stepped forward, who stepped into the mutual aid position, who stepped forward to be volunteers, who were really the glue that kept particularly some of those isolated, frailer, elderly people connected, but also with their essential shopping and their medication. So I think there is something there about we need resilience in our communities as well as we need resilience in the NHS. And another just reflection for me is the issue of the interconnectivity between all our different services. So what we've had for quite some time is some investment in the NHS, perhaps not as much as we want, but nevertheless growth in recent years. Whereas local government is going in completely the other direction, which means it drives a lot of traffic to the NHS. So many of the poorer, we had Michael Marmot open our conference for us, and so he was showing us graphs of where disinvestment has happened in local government and how there's an absolute correlation with high deprivation and disinvestment from central government to those areas. So what we're seeing is a drive of more traffic towards the NHS because we're not investing in our local authorities. In fact, many of them in the poorest areas have had 60% cuts. So they're really strapped to be able to step in and do some of that work that we need done, the sort of, the early intervention, the prevention stuff, the stuff that keeps people connected, the stuff that keeps people well. And I think also that impacts on Healthwatch too, because we're commissioned particularly through local government. So I think we need, for us, it's that bigger picture too that's crucial. But if we don't get investment in social care for sure, and a reform of social care, but even doing that will not drive enough traffic away from the NHS unless we have our investment in housing infrastructure. So the other big issue, another big theme throughout our conference this week has been around inequalities. And what's all of our roles in reducing those inequalities, and what are our roles in removing barriers for people who are furthest away from services. So I think our part of the reset has to be about resetting different expectations of how we go to people rather than they come to us, how we understand communities more rather than expect them to blend in with what we do. So there's a lot for us to really think about. And as we know, the spending review is just 1 year. The disappointment across the sector was palpable, but understandable, I suppose. But I suppose my final point on that is we need, in the next spending review, we've got to have a much more holistic approach to people's health and well-being and living in healthy cities and places, which will include the NHS, mental health, well-being, social care, investment in the staff, communities, voluntary sector. Because actually, I'm not sure that we're entering lockdown today, and I'm not sure communities have the resilience to step up again, and they are not being asked to either. So that's my few reflections. I agree with you completely, and then add some Healthwatch perspective.
No, and thank you so much. And clearly that we absolutely agree with that point about the holistic view, and there is a risk. Whilst we argue for investment in the NHS, absolutely, there is a risk that a government sees that as a solution to the health challenges it faces, and clearly it's not. It's about all public services. It's about education. It's about housing. It's about those whole set of services that we're relying on in our communities. And I think that point you make about the disinvestment in local authorities and community resilience, they're very much related to each other, particularly in some of our most deprived and challenged communities. In relation to inequalities, I mean, the particular contribution that we're taking forward is that NHS England have established us to set up the Race and Health Observatory. It's not the only area of inequality that's been highlighted as a result of the pandemic, but it's probably the most disturbing one. And we've just recruited a colleague, Habib Naqvi, who's just in the process of setting up the observatory. And that's designed to both advise NHS England on how it sort of structures national service strategies, but also then to help our members actually in terms of how they deliver them, because we know right across the services that we provide, we see poorer access, experience and outcomes for different BME communities. So there's a sort of set of practical actions that we're looking to support and lead there through the observatory. And that point about trust is really well made. I think I would also add patience, I guess. I think what we see is a lack of understanding of how change is actually enacted in communities and in our organisations. And so what gets measured a lot, I think increasingly in the NHS now, is the inputs. Well, we've told you an input to make to deliver a particular strategy. And what we're going to do is measure that you're delivering the inputs. And all nuance is lost, all sense that actually the best way of delivering something in Kirklees, where Rory used to be, is not necessarily the way that would work in Nottingham, where I am, or the way that would work for you in your whatever borough of London you're in, Imelda. And that actually local leaders and community and patient organisations do know the best way of delivering the change in their circumstances. And that's not to, the risk in that, of course, is that we make excuses and don't do what we've agreed to do, or don't do what our communities need us to. But we do need a little bit of trust and a little bit of patience whilst we, if we are set an objective, we need to be given the discretion to deliver the objective. And we just, I think over this last 10 years, we've seen that eroded, particularly in the NHS. Yes, and there's a level of kind of micromanagement and reporting and tracking, which frankly makes our teams not face their patients and their communities, but face the spreadsheet and the regulator. And that's not right. And you're right, that was stripped away during the pandemic. And I think we were better for it. And we absolutely want to keep that. We still have to be accountable. Yes. We do enormously important and risky things with and on behalf of our communities, and we have to be held to account for that. We're the biggest spender of public resource in the country. We have to be held to account for that. But yeah, we need to be trusted to kind of deliver against the objectives that we're set. If we're not delivering, intervene and do what you have to do. But absolutely trust the people on the ground too.
Yeah, I think that was very much a pick up to you, because of course the command and control from NHS England is received very differently if you're working in a local authority. You just get to tell me what to do. Well, shall we go to some questions now? So we go to Bren. Bren, if you could start us off with some of the comments and questions, please.
Indeed, I'm going to start with a couple of questions that we got in advance, and it's also going to allow me to test the technology, because I'm now going to try and bring Kat in from West Sussex.
Yes.
Hello.
Can you hear me okay?
We can hear you very well.
Superb. Test over then. Well done, Brem. So yes, from West Sussex. So it's a granular question. What needs to change so that the NHS, in particular primary care, general practice, can respond rapidly to business needs? So for example, getting in more phone lines when existing ones are being taken up by increased phone consultations, thereby blocking the inbound lines. What we've heard is the system NHS response is to perhaps think about asking patients to be more patient. Surely this isn't the answer. Thank you.
Do you want me to?
Yes, please, Danny.
Yeah, thanks, Kat. And I had a fantastic 2 years working at St Richard's Hospital in Chichester, so I know and love your part of the world. for us, I think it speaks to that lack of a kind of a proper plan for capital investment in health services wherever they're delivered. And I think that puts patients and our clinical teams in primary care, in your example, but in other settings as well, in intolerable positions where they know there's more they could do to help patient access or to improve their ways of working, but actually they haven't got the resource to invest in whether it's technology or facilities. And we just haven't had that proper sense of capital investment. What I think we're increasingly arguing to the government is that given the next few years are going to have to be about regeneration and economic recovery, the NHS as the largest public service in every locality, as the largest employer in every locality, can actually be a real vehicle for that capital, for that recovery through capital investment. So yeah, what we're asking for is a proper long-term plan, which would of course include our colleagues in primary care.
Thank you very much. And Bren, do you have another question?
Pardon me. This one is going to be from Siobhan McCurrock at Healthwatch Portsmouth, which probably builds on the new relationship between the NHS, people and communities theme that is in Reset. So over to Siobhan.
Okay, thank you very much. And test number 2 on its way. Everyone hear me? You're smiling, so I guess that's a yes.
Yeah.
Marvellous. So my question was with regard to encouraging systems to be more pushing the preventative care message. There's an awful lot of reactive messaging, but the preventative health agenda doesn't seem to be as loud as some of the other messages that are coming through in the Reset. So I just wondered what your thinking and colleagues' thinking is on that, to encourage not just the healthy conversations. Oh my God, my battery's running low on me.
Don't worry.
Lose. Hold on. So good timing as ever. There we go. Sorry about the comedy moment. So I was saying that yes, preventative healthcare should be a high agenda item for the Reset planners, because not only is that efficient in terms of NHS resources, but it helps people and communities to have the self-reliance, the self-care that people yearn for, if only there is some freedom for the systems to allow a bit more freer thinking on the preventative side.
Okay, yes, but I'll pass back to you, Danny.
Yeah, of course, and I absolutely recognise the point you're making, Siobhan. And clearly, it's in the time of my career in the NHS, it's been a massive thing that we've wrestled with, both in terms of how we set that agenda, but also how we give the public far more resources and control over their own health. I think, though, the thing that does most clearly come through the experience of the pandemic is the issue around inequalities. That actually there are certain communities, I've talked about BME communities, but there are others as well, that actually the pandemic has highlighted that those actually need to be a particular priority in terms of that population health agenda. So that's the lesson that our members have drawn out for us from the experience of the pandemic. It doesn't undermine anything that you said. I think it just highlights, the Reset conversations were about a particular set of priorities, and I think the urgency now of addressing those inequalities is manifest. There's clearly some work happening in NHS England already, some work that we're going to be taking forward, and some stuff that the government are looking at more broadly. But that is massively important and massively challenging. It's decades of either discrimination or decline in public services, and we need to find ways of overcoming that very rapidly indeed.
Okay.
And Danny, a focus on inequalities and our role in reducing that has been a major theme of this conference, but actually it's been a major theme for Healthwatch all year.
Of course.
And there's some really interesting work going on. Just during this week, we've heard some great work in Haringey with the Turkish and Kurdish community, particularly around COVID and how to get messages across and how to get people to comply, and really interesting stuff. Likewise in South London or Mali community, and we've got a new colleague who's joined us from the network, Joy Bichon, and she's doing a piece of work where we'll be able to have a much clearer view about what's happening across the whole country, because I think there's some really fabulous work happening with people who are much harder for the NHS or social care to engage with, but because our organisations are more rooted in communities, they have a greater reach. So we'd be very happy to share that work with Habib and feed into your work, because I think we'll have a different take on it. And it's a piece of work we really want to develop so that we can be really proud of the work that we do in this area and expand our work in this area too. And
I think that I will flag that up to Habib, and we've absolutely recognised in establishing the observatory that part of what we have to do is also identify what matters most to the communities themselves. And of course, there's a particular risk that because we use the shorthand descriptor of BME or BAME, we assume that these hugely diverse communities are in some way the same. And of course, they're not. They're different challenges, different experiences, different needs. So anything that helps us have a richer understanding of what will make the biggest difference for people will be hugely helpful. And of course, the NHS has to get better at this itself. The risk is that we design and deliver services in a fairly one-size-fits-all kind of way, and it's normally a fairly white male size that we design the services around. It's not a unique challenge for the NHS, a unique challenge to the NHS, but we've got to get better in terms of how we design and deliver our services, that we can reflect the diversity of the patients that we're treating. Yes,
and in some local areas, of course, particular NHS institutions are particularly good at it, and they really know their communities, and they do specific work, and they'll commission work within those communities. And I happen to live in Hackney, so I know what happens in my local health service, and they do an incredible work with the very diverse, including a large Orthodox Jewish community.
Yes. It's incredible, and it is that variation. I remain convinced that for most of the problems we face in the NHS in terms of operational issues, the answer exists somewhere else already within the NHS. It's just about how we learn from each other and how we bring everyone up to the level of your colleagues in Hackney or wherever it may be.
So it's not starting from a zero base.
No, indeed.
Different parts. So Rory, back to you now, and you have to pull out some questions or comments from the chat box.
Yeah, so just picking up some of the questions. Thanks, Imelda. Danny, the question from D. Dillistone is that the public is being told the NHS is open. Healthwatch is being asked to help reinforce that message with users, carers and networks. But Healthwatch is hearing from patients about cancelled appointments and issues with access. How do we manage expectations and ensure that people are receiving the healthcare they need in a timely manner?
And it is really difficult, and I'm really grateful, and I know our members are really grateful to Healthwatch colleagues for the role you play in doing that. And it is that really difficult trade-off that I talked about in my presentation. We've got the pressure of COVID services, which is growing all the time, particularly in certain parts of the country now in terms of admissions and quite serious illness. We've got an absolute commitment to maintain the non-COVID services and to try and keep as many services in place as possible. We've got winter, and then we've got the added pressure of the vaccination program when it comes. The example I was talking to a colleague about this morning is the trade-off, for example, around critical care capacity. There are some operations, I know from my own experience, there are some operations you can only book when you know you've got a critical care bed available to treat the patient post-operatively. Well, if there is a COVID patient, or more and more COVID patients are taking up those critical care beds, you just aren't able to safely carry out the operation. Now, frankly, there are occasions when we need to be better at explaining that within the NHS, and our clinical teams do their very best to try and explain those circumstances to patients, but clearly there are instances when we could do that better. But I also do think that the government, and we have said this to them, they need to play a clearer role in explaining some of those difficult choices and trade-offs. That absolutely we do want people to come and see us. We do want people, particularly if they're worried, examples we've looked at in recent weeks and you've helped us with are around cancer. But if people are worried, they do need to go to their primary care physician. They do need to be referred on for specialist treatment. But in the process that follows thereafter, there may be disruption just because capacity is being consumed by the more urgent imperative of COVID right now.
I think some of the issue that we see with NHS in a sort of general way, but services, is communication is poor. So you'll just get your letter saying it's cancelled, won't you? It won't say it's cancelled because of these reasons, and but here you can, but here you can speak to somebody about pain management. Here, this is our best estimate that we can give you. It just says cancelled. We'll be back in touch. And it's the same with we had a lot of feedback around primary care, and that moved to telephone triage and moved to online triage, but nobody bothered to communicate that in advance. So people spent a lot of the time arguing about, well, I don't want to talk to a doctor on the phone, I want to see one, because no one got round to telling them actually you'd probably prefer it if you just work with it.
No, and please, I'm not excusing, and I don't think our members would excuse themselves from needing to do more in that communication role, both organisationally and at the kind of team and clinician level as well. And you're absolutely right, Imelda. Sometimes it is just clearly setting out some quite simple things and stressing to people the benefit of a different way of accessing, as well as being clear about we've had to delay your treatment now, but we expect this is the alternative, or we expect to be able to kind of rebook you. And the kind of the sudden kind of message that ends a course of treatment or disrupts it is very distressing for patients and their families.
And across the NHS, we just don't invest enough in communications.
No.
Institutions don't, and the system doesn't. So Rory, have you something else you'd like to highlight?
Yes. So next question from Gillian from Healthwatch Leicester and Healthwatch Leicestershire. I'm asking about the NHS England board meeting where 1.4 billion of additional funding has been allocated every month for the next 12 months, made available for covering NHS services. And Gillian is asking whether this funding is just for services or whether it's going to make a contribution towards staff and the staffing issue that we have in the NHS as well.
It was probably more of a question for Amanda earlier than for me. I mean, my understanding is that there is money being made available. I don't think it's enough to try and help with the implications of the pandemic in particular. And there may be some money made available for things, and there's been some money made available for things like long COVID. Obviously, for the staffing pressures, there's a very long lead-in time to the sort of permanent solutions for us. That there is some investment in international recruitment, and that will make a difference. But we're talking about much longer timescales, unfortunately, to address, for example, the 40,000 vacancies we had for nurses before the pandemic. We're talking 4 or 5 years before we truly see the benefit of investment, any investment that might be made there.
I think you're right. I think that is a question for Amanda, and perhaps Bren, you can make sure I get that, and I can email Amanda that question. Okay, thank you. And so we're going to Bren or Rory. I'll my best friend has sons. One is Brendan and the other one is Rory.
Whoa.
So I keep thinking you're our neighbour's children, but you're not at all. So who goes?
Occasionally behave like it. The next question is from Emma at Healthwatch Islington, who said it's a really useful reminder of the pre-pandemic situation. How can local Healthwatch support this locally, or is the challenge more effective at a national level? Is the lack of investment is a national problem? But she adds, she really does trust the local leaders to make good decisions and put resources to good use. But I think key to this is, how can a Healthwatch support that?
I think it's both and, you know, and I think often because actually the local contacts that you have with, for example, elected politicians are a useful and powerful route to kind of make real some of the challenges for the Treasury and the Prime Minister, particularly if those are, you know, your local politicians are politicians from the governing party. I think that does help. I know in some of the engagement I've had with MPs and ministers that actually their awareness of, for example, social care has grown enormously over the last 5 years because of the contact they've had with it in their own constituencies. And so I do think that plays an important route. I think one of the things that we're very committed to doing, and I know others where they have the freedom to do this to more publicly lobby, is to try and work together far more effectively to do that. I think the risk in the health service in particular is that we have a slightly discordant chorus of what priorities are. And I know it was very powerful as we went into the last election this time last year for the medical royal colleges to say actually the priority is emergency care, it's care of the elderly and it's social care. And to have the president of the Royal College of Surgeons saying that's the priority is enormously powerful, because the risk over the years has been, you know, the surgeons argue for their bit, the radiologists argue for their bit, primary care argues for its bit. And the more we can do to have a shared sense of priorities, and it's obviously what we try and do as a confederation, because we cover the waterfront of health and social care providers, then I think the more powerful and more impactful that is as well.
Thank you very much. And Rory?
Thank you. So I'm going to take a question from Mark Farmer in the question box, and the question is about local resilience forums. Mark's interested. It would be good to know if Healthwatch tends to sit on local resilience forums, which have been really important in the last 6 months. And he says, we're not in our area, so throughout the crisis, our voice and that of local patients and carers was not heard in the management of the crisis. Danny, relationships between the NHS and local government have been significantly improved over the last 6 months, but do you think that there might be a hole in not having patients and carer views in that part of the system?
I think, and of course the risk is whatever committees or anything else we form, it's not, you know, it's about behaviour and culture and approaches, you know, undoubtedly. And I think we picked up on this in the reset report that we published on patients and communities, and in the feedback that we got from Imelda and Bren in particular. You know, clearly there were times in the pandemic that, because of the speed of decision making and because of the rapidity of the change to services, patients and the public weren't consulted, and that isn't something. You know, that isn't something that we should think is the right way of running services. So I think there were moments where absolutely, and our members accept this, where we went backwards actually slightly in terms of that level of engagement with the public. And it, you know, I think we all understand why that was for that particular period of time at the beginning of the pandemic. But we need to very quickly now rapidly recover a better way of doing those things together. I do think the relationship with local authorities in most parts of the country is stronger and is getting stronger because of the response to the pandemic. But I also know, and I think you'll have heard from Rob Webster if you were at his session earlier, that the most thoughtful of our system leaders, our ICS leaders, absolutely recognise that part of their responsibility is to make sure that whatever they do is underpinned by, is properly informed by patient and community engagement. And again, there will be parts of we will see variation between parts of the country in terms of the quality of that engagement. We see variation between our services in terms of the quality of that engagement. You know, very different ethos in mental health, for example, compared to some acute settings. So we've got a huge amount to do there, but I think one of the encouraging things as part of the reset conversations that we had was that our members did recognise and accept the feedback we got from Imelda and others on your behalf, and did recognise that there's lots more for us to do as we go forward.
Now, Mark, I don't I don't know how involved we were in local resilience forums or whether that was the right place for us to put our efforts. I just wonder, we have a chat function. Holly, do we have a hand up function?
We don't, I'm afraid, Imelda. Not on
Okay,
this
so
one.
in the chat function, if you're part of your local resilience forum, could you put your Healthwatch name and put yes? If you're not, put no. And if you don't think that really matters, that you didn't feel like you should be there, if you could just go say whatever. I have no sense of how involved we were, or whether we should have all been on that resilience forum or not. So that's interesting. It'll be different all over the country. So shall we go to our next question, please? Bren, I think it's over to you.
Yep, and I'm going to bring two questions together. So from Stuart at Coventry, in quite properly seeking a sustainable way forward for social care, do you have a view on where the responsibility for overseeing social care should lie? How do you see the roles of local authorities and those of the NHS? Imelda referred to local authority funding being severely reduced and that there is no sign of council cuts will be reduced. So is the NHS better placed to lead in this area? And then from Phil, do you think we will ever get an integrated health and social care? So two aspects of the second.
So I think in terms of the second question, thank you both, but in terms of the second question, I think we're in a better place than we ever have been, but we've still got enormous work to do. I think in some ways we've had the challenge within the health service of also integrating healthcare itself, and but that is still something of a work in progress in terms of the relationships and collaboration between different NHS organisations. Again, I think that's better through the pandemic than it's ever been, and we've got to build on that. And clearly, the legislation will reinforce that. I think in terms of who's best placed to be the delivery mechanism, the overseer for the sort of reform of social care that we're also desperate for. Our members don't tell us that they believe that the NHS is better placed or uniquely placed to do that. I think we're very respectful of the fact that delivering social care services is very different to delivering NHS services, very different. There is it's a very different market, it's a very different set of organisations, it's a very different set of relationships with clients and communities and their families. So I don't believe we don't hear anything from members about that, to be honest. What we do hear is that lack of a plan, that lack of certainty from successive governments destabilises the market, makes it very difficult to recruit and retain workers, to give them proper working conditions and pay, and to give them proper access to career development in particular. After many long years in the NHS, I would always caution against the bureaucratic or structural response to a problem. We've reorganised ourselves countless times in my career, but some of the fundamental problems outlive every reorganisation. What we need for social care is investment, and we need a plan, and we need a difficult set of conversations with us as an electorate about what it takes to properly fund and sustain social care, and there's some political bravery that's needed as a result. There are undoubtedly, I suppose the final thing I would say, and it's not directly in the question, but it's an interesting thing to add, that there are some things, of course, that could be done relatively quickly through NHS funding routes, which might help. At the moment, there's the 6-week commission, funded commission from the NHS for post-acute care needs. Extending that funding stream might help the sector. I do believe that the ICSs provide a vehicle for better cooperation between the commissioners of social care in local authorities and the providers of social care and the health service. But there's a lot of work that's needed to be done to build those relationships and to build mutual understanding as well, to help NHS leaders understand sometimes that some of the solutions for social care don't lie within the NHS, they lie elsewhere within the community, and there's always a risk for the NHS, and I speak as a lifelong NHS person, that you do rather assume that what works in a massive, the last trust I worked at here in Nottingham, I think has about 14,000 employees now. The things that you can do in a business that size will not work in a business that employs 20 or 30 people. There's just something about understanding the differences as well, and we've still got a bit more work to do in that regard.
That's a really helpful answer. Thank you. We have time probably for 2 more questions. So Rory, I should come to you.
Yes, so Imelda and Danny, you've both talked about the benefits of letting local leaders make decisions for the benefits of their population. And Imelda, you again talked that Sarah Pickup from the LGA supported that idea of trusting local leaders to make decisions. The question in the box is whether that localism, letting local leaders lead, will move us towards a postcode lottery situation where you may get different services in different parts of the country. Your thoughts on that, please?
I don't mind going first, Danny. You probably got more to say on it. My first thought is that we have a postcode lottery anyway. There is nothing to stop the commissioning of services, whether that's local authority, CCG, or specialist commissioning, to put frameworks in place that still make things happen at a certain time. But you might put a target around how quickly you'll get seen by A&E, that might be a sort of standard that you look to across the country. But actually, where it's situated and whether that's in 3 different places, because actually there's a mountain between, that has to be local. That has to absolutely be local. Likewise, local needs are just so very different. You can't design a service sitting in central London that's going to work for Cornwall or Cumbria, because you just won't get it. So I think we do already have a postcode lottery. I don't know that that's a bad thing. Danny, back to you.
Again, we don't tend to these days talk about the way in which resources are allocated in the NHS. I know for a long time earlier in my career, we all knew a lot about RAWP, the Resource Allocation Working Party, and how it allocated resources. But I think there are still issues there that drive some of that, those differences. It's about the availability of resource. Some of the differences we see are about the availability of staff, of course, and some of the differences are historical. We do see a greater concentration of particular services in London and the South East, for example, for all sorts of reasons. I do believe that it's appropriate to make the case for those differences to be removed. I do believe it's appropriate to make the case for national investment or national standards to do that, to achieve that. But I also believe that once the objective is set, that the delivery of that objective is best done by leaders in a local system working together. And those leaders aren't just NHS leaders, they're leaders of other public services, they're people who represent patients in the community as well. There are no quick kind of fixes for some of those differences that we see, whatever language you use to describe it, the language of lottery or inequality or whatever it may be. But I do think that the local leadership is best placed to do that. I think absolutely it can be reinforced by setting clearer national direction and clearer national objectives and standards.
Thank you. Thank you very much. And if we just take one example, which is the role that the fire service has played in house safety and identifying frail elderly people that need support, that has to come from a local leadership style, doesn't it? Now, Danny, this has been really fascinating. We've run out of time. I feel like we're just beginning in lots of ways. I really, really appreciate you giving your time, and also to Rory and Bren for all the work you did behind the scenes. And I see that many of you have contributed in the chat room about whether or not you're part of local resilience forums or not, or whether it mattered, whether you had good links in. And I appreciate that. I'm going to have a good read of that, so I have a clearer picture in my mind about what's happening across the country. So we've come to the end of this session. Thank you everybody for participating, for being in the audience. It's a good turnout. We're coming towards the end of our conference, so we'll see you all back at the to listen to. We have Sir Robert Francis, our chair, coming back to do a final address for us all. And Danny, once again, thank you so much.
Thank you.
Thank you. I think that's